segmentation of distal left main and role of IVUS during left main PCI pre-procedure, during procedure, and post-stenting. Why do you need IVUS or any form of imaging for left main PCI? This is one subset. There is an absolute mortality benefit, which is not in small number, ranges between 4% to 7.6% absolute decrease in the mortality. So one subset, if you want to use IVUS or any form of imaging, that is your left main PCI. Particularly when the lesion which you are going to deal is complex, particularly the distal left main lesions. And in specific, if you are going to use 2 stents, that is when the maximum benefit happens when you use imaging in left main. And what are the various tips and tricks you use for left main? One, use a non-aggressive guide catheter. Align your catheter coaxially. And always, if you want to image the left main ostium, it is best practice to disengage when the IVUS catheter is close to your ostium. And always pre-dilate in case of tight lesions, because it takes some time for you to image. It can create ischemia. And it is important to keep your imaging depth to the maximum, so to not to miss any details in case of big left mains. Do always an automatic pullback, where sometimes in left main the image, the length matters, accurate estimation of length matters. For bifurcations, it is a good practice to do pullback from both the branches. And how do you size your left main? The sizing should always be done from the pullback in the most coaxial branch. More often it is from LAD, to avoid oblique. So whenever you do from the angulated branch, the imaging what you create is an oblique image that results in overestimation of your left main size. So it is important to do your left main sizing from the most coaxial branch. And if you want to image your side branch ostium, that is again, it is LCX. Again, it is very important to do your size estimation from the side branch rather than from the main vessel, where that oblique imaging happens. And particularly when you use volcano type of catheters in an angulated branch, there is a phenomena called a leap. The catheter jumps when you come from angulated branch to the main vessel. So it is important to always use a push forward phenomena, push forward to acquire images, particularly in the angulation, not to miss any of the MLA in that place. And how do you segment your left main into different parts? It is almost like what is happening with your bifurcation QCA. It is divided into 4 segments. Just to see this longitudinal view, where is your left inflection point of your side branch. The vessel proximal is your main vessel. And just see the figure of 8 from side branch and main vessel pullback. And where you see the first frame of figure of 8, that is your ostium of the distal main vessel or side branch. So the segment from the figure of first frame of figure of 8 to the proximal 3 mm is called as ostium of the distal main vessel. And in the side branch fullback from the figure of 8 frame into the 3 mm distal, it is called ostium of the side branch. And in main vessel pullback, the area between the figure of 8 to the inflection point of your side branch is the area of polygon of confluence. That is how the IVUS segmentation of left main bifurcation happens. It is almost similar to what you do with the bifurcation QCA. So what are the various roles of pre-procedure imaging? One is assessment of LMCA stenosis severity. Second is evaluation of ambiguous lesion morphology. Third one is stenting strategy, 1 stent versus 2 stents. And fourth one is lesion preparation. And fifth one is stent sizing. So what happens with assessment of LMCA stenosis severity? In contrast to non-left main lesions, there is a good correlation between IVUS and FFR in the left main territory. The MLAs varies between 4.5 millimeter square, that is mainly from Korean studies, to 7.5 millimeter study, that is from Mayo Clinic study in the Western population. So what parameters use for assessment of intermediate lesion evaluation? Only one area that has been prospectively evaluated so far, that is the LITRO study, which is used an area of 6 millimeter square. Anything less than 6 millimeter square, they intervened. More than say are equal to 6 millimeter square, those lesions differ. If you see the outcomes, there is no difference whether you intervene based on your smaller lumen area and differ based on your bigger lumen area. There is absolutely no difference in the outcomes. The worst outcomes happen in a group of people where patients had less than 6 millimeter square lumen area and were treated medically. So why not 4.5 millimeter square area? This is a Korean study. If you see that we use a 4.5 millimeter square area, that is 41% mismatch. Most importantly, 25% reverse mismatch. You end up missing 25% of the patients with significant lesion with ischemia that may be missed if you use the 4.5 millimeter square criteria. So how do you use this one? When you find an intermediate lesion in the left main area less than 4.5, and you have to you just advise revascularization. Anything more than or equal to 6 millimeter square, deeper revascularization. When you have in between, you have to rely on other non-invasive or invasive modalities for assessment of ischemia, or if it is not feasible, assess the patient's body habitus, age, presence and absence of remodeling and plaque burden to make decision regarding revascularization. So this is an example of 81-year-old female and with unstable angina who previously had LAD RCS stents. Both came with ISR. She additionally had borderline LCX and distal left main lesions. She had for repeat stenting of this LAD and RCA lesions. Then we assess this LCX. You see that this area is more than 4 millimeters square, which has a very high negative predictive value for ischemia, so that was left alone. And this 81-year-old small stature female, this area of 0.5 millimeters square, even though it is less than 6, can be left alone safely. That is what done for this patient. And the second role is evaluation of ambiguous lesion morphology. You see both the lesions here, both appear similarly. And on your angiographic image, the first one is actually a calcified nodule causing significant stenosis at the left main ostium. The second one is obviously a STEMI patient with a thrombus. Both appear similarly. Suppose this patient is present in ACS but non-STEMI scenario, and IVUS helps in differentiating between these two lesions. And this is another patient, 60-year-old female, diabetes, hypertensive, unstable angina, lesions in LAD and OM, come for PCI. This angiogram was done using a 5 French diagnostic catheter outside, but when we use a 6 French catheter, we observed significant ventricularization. So what I was showed here, you just see that the distal left main had an area of 26 millimeters square and the diameter of 6 millimeters. And if you see the ostium, the diameter is only 4 millimeters. This is an example of significant negative remodeling, which is commonly occur in ostiums. Suppose you size based on your distal vessel, this patient, you might have produced an aortic root injury. So fortunately, this patient had additional lesions in LAD and LCX, and both were positive by FFR and went for surgery. And this is a 27-year-old female, no cardiovascular risk factors, presented with inferior wall end STEMI. This is an angiogram, smooth appearing distal left main LAD, LCX lesions. So this is what the IVUS showed in this patient. You see that IVUS pullback was done from, the wiring was not very difficult, fortunately, in this patient. And this is what the IVUS showed. If you see that there is a spontaneous coronary dissection extending from LAD into the left main. You can just see clearly here. This is, and absolutely there is no atherosclerosis in this patient. And this is the pullback from LCX. So this is a case of spontaneous coronary dissections presenting at STEMI. This patient was left alone, and she's still doing well. This has been done, I think, 2018 or 19. And because there's no flow limiting lumen compromise in this patient, except a bit narrow area at that LCX ostium, the remaining area looked good, and she was left alone for medical treatment. This is an additional other patient, 36-year-old female, diabetes, ostium secondum ASD, severe PAH, bidirectional sign, moderate alveolar dysfunction, presented with recent onset angina. So, and this is what that angiogram showed, and this is an IVUS image here. You can just see that eccentric slit-like orifice of your left main ostium. So this patient, so this is actually what we saw at the ostium, and this patient underwent a stenting for the left main with a 4 into 12 millimeter DES and final optimization, and this is what the final images. So this is a significant left main compression produced by your enlarged dilated pulmonary artery. This is another patient, 41 female, ostium primum ASD, severe PH, bidirectional shunt. This patient did not have much of angina, but during cardiac catheterization, this was what the pediatric cardiologists observed. So we did an IVUS imaging and an IFR for this patient. IFR is 0.9, and you see that the lumen areas, even though it appeared very narrow angiographically, it is a well-preserved lumen area. This patient was left alone for medical treatment. And this is an elegant study published in 2017, where what are the various things you observe in a patient with severe PAH. One, this is normal distance. You just see that there is a gap between your left main and pulmonary artery here. Even though here the both are contiguity between these two, but there is no compression and there is some form of dislocation, but still lumen areas are adequate. This is what happened in our second patient, and this is what happened in our first patient. So where there is a significant left main compression from your enlarged pulmonary arteries. And this study, about 94 patients had abnormal CT angiogram, where they found the last two patterns and they underwent invasive evaluation. More than 50% diameter stenosis was observed in about 48 patients, and 45 patients underwent a PCI, and 41 had sustained angina relief. So it is not a very uncommon scenario when you deal with patients with the Eisenmenger syndrome with the grossly dilated pulmonary arteries. The one significant finding is most of the compression occurred when your diameter of your common pulmonary artery is more than 40 millimeters. And this is an interesting patient, 42, female, diabetes, hypertension, smoker for a female, and asymptomatic, and had a positive stress test. So he came for a diagnostic angiogram, positive stress test. This is what the first injection. What do you think has happened to your left main? Any guess? And this is what happened after first injection. They stopped injecting and patient remained hemodynamically stable. In view of suspected iatrogenic dissection, she was advised emergency CABG. However, patient refused to undergo the same and got discharged from the hospital. And 2 weeks later, came to our OPD and reviewed. So what do you think? What are the various possibilities in this patient? What has happened? Patient absolutely remains stable, nothing. It is okay. So actually, most probably an iatrogenic dissection, highly unlikely to remain stable, that type of dissection. And the second one is spontaneous coronary artery dissection. Again, it's a very uncommon to get in that, unless you have a left aortic dissection that was extending into left main. Is very unusual to get. So somehow we convinced the patient for an IVUS, and it's this, actually this wiring took almost half an hour. Every time you put wire, it will just go on blindly. But see, all the time we were doing in caudal view, this is what happening here. You just goes and blindly end in the cavity. Once you switch to cranial view, we left the wire there and use the second wire. You can just see that how compromised is your left main here. And after wiring, and this is your IVUS. Any guess? What do you think this is? And it is a very significantly narrowed left main. If you see that it is a ruptured plaque in the left main. So it is not a dissection, it is an extensive ruptured plaque. You can see nicely the fibrous cap remnants and the cavity there. So this patient underwent stenting for the left main. So this is what the final result is. And the third role is stenting strategy, to select between one stent versus two stent strategy. This is a study from Korea. Whenever your side branch lumen area, still lumen areas less than 4 millimeters square and plaque burden of more than 50%, those are the patients who had a significant FFR post stenting. So those patients maybe start with two stent strategy rather than a single stent strategy. And fourth one is about lesion preparation. We now have calcium score, IVUS-based or OCT-based calcium score. Whenever your score is more than 2 and you need some form of lesion preparation using specialty devices for optimal stent expansion. How do you size your stents? Stent sizing is based on the landing zones, and the landing zones are the site with no plaque or the largest lumen with less than 50% plaque burden in the proximity of the lesion. And main vessel landing zone should be at least 8 millimeter proximal to the carina for helping you to get a good part done. And stent sizing is based on the distal main vessel landing zone and side branch landing zone. And stent diameter is average of the distal landing zone lumen diameter upsized to the nearest 0.25, taking into account the stent expansion limit in the main vessel. And main branch stent length is the distance between the two landing zones in the distal main vessel and the proximal main vessel. And the side branch length is the distance between the distal landing zone and the intended amount of protrusion into the proximal main vessel. Part balloon is sized to the proximal landing zone, averaged to the reference lumen diameter and upsized by 0.25. That is how you size your stent and balloons for part and post dilatation. And during procedure, and IVUS or OCT helps in identifying the following things. One, you do a KRISH. It helps in identifying whether the KRISH is complete or incomplete. When you have an incomplete KRISH, it may be very difficult to wire into the side branches. This is an example of incomplete KRISH. You can just see that wide gap between the stent studs. And the second role is to identify whether your crossing is proximal or distal. It may be a little difficult with IVUS. When your wire goes close to the carina, that is distal KRISH. When it is close to the bifurcation point, and it is a proximal crashing. This is an example of a distal distal crossing. You just see that the wire comes into the main vessel closer to the carina. So that is how you identify distal crossing with your IVUS. Another important thing is IVUS or OCT helps in identifying abluminal wiring. Here you can just see that this is an example of abluminal wiring. Wire lies behind your stent studs rather than inside the stent studs. And for identifying side branch crossing, they just are showed elegantly in his cases. So OCT might be better comparing to IVUS because of its 3D capabilities. And this is an example of coulate stenting where the side branch was crossed through the distal cells. You can just see that the wire is going through the distal cell. And here again, wire you can just see going through distal cell. And if you see in two-dimensional imaging, wire is coming closer to the carina. That is how you identify distal and proximal crossing. And after stenting, you do the routine parameters of under expansion, malposition, geographic dissection, and longitudinal deformation. How do you define expansion? Different criteria have been used. The easiest to remember is expansion should be more than 90% of your reference of either the side branch and the main branch and the proximal main vessel. So that is how you define expansion easily. These are multiple numbers. The latest one is 11.8. 8.3 and 6 millimeters square. That is what the recent Korean study with the double KRISH data showed. Just remember a number, at least you should be end up getting at least 80% of the reference. That is what at least a minimum requirement for your expansion. And malposition in left main, try to correct any malposition, even though significant malposition is defined as more than 400, length of more than 1 millimeter, because of the fear of abluminal wiring. Correct any malposition, at least in the left main. So other places, any malposition more than 400 microns and more than 1 millimeter length requires correction. And geographic miss and any plaque burden more than 50% at the edges, reference lumen area less than 4.5 square millimeters within 5 millimeter of the stent edge. Better to correct. That has been again shown by Dr. Ajay in his presentation. And edge dissections, the same criteria, extension into the media, angle more than 60 degrees and length more than 3 millimeters. That is what the dissection which need for the treatment. So in some examples, this is a patient, left main bifurcation, double KRISH. So this is how the optimal extension should be. You see that LCX ostium is 9.6 millimeters square, LAD ostium is 12.1. Your polygon of confluence, we no more use this parameter, but it is 10.8 and the left main is 14.5. This is an example of optimally expanded stent. And this is a patient who had left main to LAD pulled back, and part was done with a smaller balloon. You can just see that there's a gross malposition in the left main, and this is what happened after optimized it. We used a 5.5 millimeter complaint balloon to oppose your studs in the main vessel. So this is an example of left main malposition. And this is a patient who had a tap stenting. And you see that amount of protrusion into the left main. So ideal should be less than 3 millimeters. So this is a large protrusion into the left main. And this is again the tap stenting. You see that very small protrusion and optimal tap stenting. And this is an example. This is a patient who had an ostial LAD lesion. The plan was to do a left main to LAD crossover stenting. That was done. And this patient is 110 kgs and severe sleep apnea. And when we were planning to do part, he took a deep breath, everything came out. And it took long time and to rewire it. So somehow we wired and the balloon flossing was done. And this is what the image we got. Anybody wants to take this one? I just play this. I was playing and I put the images here. Sorry, it is not playing. So this is an example of a deformation for you can just see that there is some deformation in the ostial part, but the main deformation is happening in the shaft of the stent. Initially, our thought process after seeing this IVUS image that we went outside the stent and came inside. And that is what the thought process is. We thought we dilate it and put an additional stent. But you see that this is one case. Stent boost gave more information than your IVUS. To see that we are actually correctly into the lumen. This deformed stents like stents that's producing this appearance of your IVUS catheter is lying outside. And this is what happened after dilating with a 3.5 and 5 millimeter balloon. See that nicely it is expanded. So this is an example of deformation that has happened in the middle of the stent rather than at the ostium. And this is your final result. And this is an other patient suspected to have some form of autoimmune disease and a tight osteal LAD lesion. And we dilated it. It was done during one of the workshops. So dilated, and 5 millimeter stent was implanted, and a nicely optimized part was done. And this is what we observed in post-part imaging. There is hardly any stents in the proximal 4-5 millimeters. So again, this is an example of longitudinal. This is almost actually, we didn't have any stent in the left main. So everything has migrated into LAD. Then we did an additional. You just see that fluoroscopically there is absolutely no stent. And so these form of things can happen. It's very difficult to predict unless you do stent boost imaging. Very difficult to predict angiographically. So further dilatation was done. An additional 5 millimeter stent was implanted. And we all know this is a very important phenomena which occurs in left main. The Excel trials shown that 6.5% is your deformation, mostly occur in the ostium, and sometimes it can happen 15% of the patient in the soft. You see that outcomes, 3-year outcomes, it is more than 100% increase in your outcomes when you have longitudinal deformation. And this is our recent study. Again, it has shown that 18.5% deformation rate in your left main stenting. And the most heartening part is if you identify them and correct it, 2-year event rate is 0%. So that is the most important role what imaging plays when you do left main stenting, because the left main is one subset where abnormalities go undetected even for a highly experienced operator. And we see some examples of stent failure. Again, this patient was done in one of the workshops. So initially, it was done long back, 2011. So this is actually operator felt V-stenting might be okay into this lesion, and lesion preparation was done. Those days only cutting balloon was available. Cutting balloon was done, and this is what we ended up with. You just see that grossly expanded LAD part of the stent, because if you see carefully, there's a big chunk of calcium sitting here that was not recognized properly. And so this is what we found. This patient had sudden cardiac arrest at home after a month. So most probably under expansion related stent thrombosis. And this is one of the patient I showed you, the long Carina tap stenting. This patient came back after 6 months. You see that the entire bifurcation is stenosed, tight stenosis. And that was wired, balloon dilated, and this is what found. It's a calcified lesion. Again, gross under expansion of the stent is a cause of stent failure in this patient. And this is an interesting patient. This patient had ostial LAD and distal left main lesion that was stented from proximal LAD to close to the ostium. Unfortunately, the stent was not enough to cover the ostium. We did an IVUS imaging. There was hardly any plaque, but the lumen was very good. We thought it is not appropriate. We can just leave it. 2 months, you see that patient came back with a tight stenosis at the ostium. So the lesson learned in this patient is when your lumen, your left main is not very big size, better to cover up to the ostium rather than just to leave it ostium uncovered. And this is another patient, 48-year-old female. This is a very unfortunate female. This is what happened actually. This lady came for AVR. We did an angiogram. Hardly any lesion in the left main, and RCA looked very good. So surgeon tried doing some root enlargement and ended up closing RCA and put a vein graft to RCA. And unfortunately, I think she has developed some injury to left main ostium as well during surgery. And this is what within 4 months she came back, and see that your vein graft in 4 months, and that was stented. And that is the time you see that left main, it was some lesion was in the left main. We did a FFR, it was 0.83. We thought we just leave it alone. She comes back in 4 months time. Again, the graft has a problem. Then cutting balloon, other things were done. Additional stent was implanted. We reassessed to left main here. this time lesion appeared to be 8 months time, that lesion appeared to be progressive, did an FFR 0.83 became 0.76 now. And so we did an IVAS. IVAS showed a minimal lumen area of 6.2 because we have a physiological evidence that the lesion is significant, and we thought we should stent it. Stenting was, it is a routine stenting. We had a lot of difficulty in maneuvering the catheter across because there is not much space in the root, and the surgeon has put the biggest possible valve. Again, it is very difficult to maneuver. So this is what done. What do you think the stenting results? Any comment on the stenting result? Looked good, right? It is stent is optimally expanded and is coming out of the ostium, entirely covering the ostium. That's what we thought. And she again comes back in 4 months' time. So it is, graft is now totally occluded. Then we just left it, no point in dealing. And there's no native option because the ostium is completely occluded. And you see that FFR 0.65. And we did the IVAS imaging. Any comment on this IVAS imaging? And so the reason is longitudinal stent deformation because there's much of crowding, most probably when pulled back IVAS catheter or pulled back your guiding, that has deformed your stenting. And so this time went back and dilated. And fortunately, for the past 6 years, she's doing well. Still she's alive and doing well, and no further events. So simple things, correct? So at this time, we just see that in the end, we took this thing, make sure that the stent is there in the ostium. So it is. So again, this is what the final result is. And these are the rare causes that I've been discussing. I think the last case we discussed, one is your neointimal coverage of your side branch studs. And this is a stent failure that is related to abluminal wiring. When they did a Kohler stenting, the wire went behind the stent cells. So this is resulting in your stent restenosis. So to conclude, IVAS guidance in left main PCA reduces mortality and improves patient outcomes, helps in procedure planning, confirms optimal side branch wiring, and confirm that appropriate nerve stop crushing and ruling out abdominal crossing helps in stent optimization. So one subset, if you want to